Hi, this is Dr. Jeshvin, General Surgeon. Today we are going to see about FMGE June 2026 surgery paper. Okay, we are going to recall the questions and we are going to have a discussion based on the asked questions. Okay, so the first question is: a 56-year-old man presents with a bleeding per rectum for 4 months. On examination, there is a 5 cm ulceroproliferative growth arising from the anal canal. Biopsy reveals a squamous cell carcinoma. There is no distant metastasis. What is the best initial treatment? Okay, there is no distant metastasis and they have given it as a carcinoma of anal canal. And the biopsy reveals it's a squamous cell carcinoma. The most common pathological classification in an anal canal carcinoma is squamous cell carcinoma. The treatment, the first treatment that is given is Negros regimen. Okay, Negros regimen is that is concurrent chemoradiotherapy. That is chemotherapy and radiotherapy is given to the same patient at the same time. Okay, once this chemotherapy or this chemoradiotherapy, if it is not successful or if there is some complications from the tumor, then we are going to proceed with surgery. Apart from that, the first management for a squamous cell carcinoma of anal canal, it is Negros regimen, that is concurrent chemoradiotherapy. Okay, suppose if the question, if they have given it as adenocarcinoma of anal canal, then we have to proceed it like a rectal carcinoma. It is very rare. Adenocarcinoma of anal canal is very rare. If the question it is given it as adenocarcinoma of anal canal, then we are going to proceed it like rectal carcinoma. Okay, so what in rectal carcinoma, what is the management? In rectal carcinoma, if the tumor is less than 5 cm from the anal verge, okay, from the anal verge, if the tumor is less than 5 cm, then we are going to proceed with APR, abdominoperineal resection with colostomy. Colostomy is done. We can't do anastomosis, so we have done an abdominoperineal resection with colostomy. Okay, it can be either most commonly it can be a permanent colostomy. If the tumor is more than 5 cm from the anal verge, if it is more than 5 cm from the anal verge, after resection of the tumor, we can do a coloanal anastomosis. So we can do a lower anterior resection. If it is done in a tumor that is more than 5 cm from the anal verge. It is understood that an anal canal tumor, it will be less than 5 cm from the anal verge. So we have to manage it like a tumor rectal carcinoma that is less than 5 cm. So we have to manage it using a APR. So if the question is like adenocarcinoma of anal canal, then the treatment option is APR. If the question is squamous cell carcinoma of anal canal, the first treatment is concurrent chemotherapy. If it is not successful or if there is any complications, we are going to proceed with surgery. What surgery? APR. We are going to proceed with APR. Okay. So the next question is: a 2-month-old male infant presents with recurrent respiratory distress and failure to thrive. On examination, bowel sounds are heard in the left lower chest. Okay, bowel sounds are heard in the left lower chest with a scaphoid abdomen. The infant also has undescended testes. The chest X-ray shows bowel loops in the thoracic cavity. What is the most likely diagnosis? So in this image, we can see there are bowel loops in the thoracic cavity. The patient is presenting with respiratory compromise. Also, we can auscultate bowel sounds in the thoracic cavity. All this points towards a diaphragmatic hernia. The patient's age is 2 months old, so it is a congenital diaphragmatic hernia. The hernia is located on the left side. That is the most common type of congenital diaphragmatic hernia. That is posterolateral, left side. Okay, that is a Botchdalek hernia. Botchdalek hernia, it is the most common type of congenital hernia, whereas Margagni hernia, it is located on the right side, right anterior. Okay, right anterior, near the sternum it will be located. It is very rare. Margagni hernia, it is present on the right side, whereas this Botchdalek hernia, it is present on the posterior aspect on the left side. Okay, through this, bowel contents can herniate and it can go into the thoracic cavity. When the bowel contents, it goes into the thoracic cavity, what does it do? It compresses the lungs. Okay, it causes it doesn't allow the lungs to grow, so that leads to pulmonary hyperplasia. That is the leading cause of complication in a case of congenital diaphragmatic hernia. Also later on it can also form pulmonary hypertension. That is a second leading cause of death in this congenital diaphragmatic hernia patients. It can be associated with congenital anomalies like trisomies. Also it can be associated with undescended testis. There can be undescended testis associated with this congenital diaphragmatic hernia. In the left side, that is in both type of congenital diaphragmatic hernia, small intestine is the most common content to get herniated, whereas on the right side it is the transverse colon. Okay, right side the most common content to get herniated is a transverse colon. Okay, also one more important point, bag and mask ventilation is contraindicated. Okay, bag and mask ventilation is contraindicated in a case of congenital diaphragmatic hernia. While giving this bag and mask ventilation, we are giving more air inside the bowel cavity. Okay, what happens? Air it will enter through the oral cavity inside the bowel. So already the bowel is in the thoracic cavity, so it can cause further enlargement of bowel cavity and further compression of the thoracic cavity, that is further compression of the lungs and further complications. So bag and mask ventilation is contraindicated. So what can we give? We can give IPPV, intermittent partial pressure ventilation. Also ECMO can also be done in this patient. How are we going to manage? Surgical management, we are going to make a circumferential incision in the diaphragm and we are going to repair the defect. Okay, repair the defect and we are going to close the defect. We are going to bring the bowel back and we are going to close the hernial defect. Okay, next, what type of electrolyte imbalance it is seen in case of a refeeding syndrome? Okay, what is this refeeding syndrome? Okay, so from the name we can imply that it is something we are going to feed the patient again. So some chronic malnourished patient, okay, they are coming to us and we are going to feed the patient either enteral nutrition or parenteral nutrition. We are going to give either enteral or parenteral nutrition. So the patient's metabolism, it is in catabolic state. Now we are going to change it into anabolic state, so it can lead to some complications. Okay, patient is chronically he is in catabolic state, that is from breakdown of fat, protein, from that only patient is getting his energy, his or her energy. Now we are going to give more nutrition to the patient, so catabolic state is converted to anabolic state. Similar to that, electrolyte and fluid, it is getting exchanged from the intra and extracellular fluid. Okay, so it can lead to complications. Okay, so what type of electrolyte imbalance? The most common electrolyte imbalance is hypophosphatemia. Okay, hypophosphatemia, less phosphate. Apart from that, that can be less potassium, less calcium, less magnesium. In this question, it is the most common hallmark of refeeding syndrome is hypophosphatemia. It can cause muscle weakness, fatigue. It can also cause arrhythmia. It can cause cardiac failure. It can cause pulmonary failure. It can cause pulmonary edema. All these complications can be seen in this refeeding syndrome. So we have to assess the patient. Which patients are going for refeeding syndrome? We have to assess and then we have to give the enteral or parenteral nutrition. Both enteral and parenteral nutrition can cause this refeeding syndrome. Important hypophosphatemia. Everything will be low. Okay, phosphate will be low, potassium will be low, calcium will be low, magnesium will be low in this patient. Okay, a 35-year-old woman presents with recurrent episodes of sweating, palpitation and confusion that improve after glucose intake. She is diagnosed to be a case of insulinoma. Which of the following tumors should be actively screened in this patient? Okay, so here the patient is a case of insulinoma. There is a triad called as Whipple's triad. So what is this Whipple's triad? In this, patient presents with symptoms of hypoglycemia such as prostration, that is sweating, palpitation, that can be confusion. Patient can go for unconsciousness. Okay, some whatever symptoms that are present with hypoglycemia, patient will present with that symptoms. Okay, once we give some glucose, patient's hypoglycemia will get improved. Okay, number 2. Number 3, when we see the blood glucose level, it will be less than 50. Blood glucose level will be less than 50 mg per deciliter. So laboratory findings also, there will be hypoglycemia. Patient will be symptomatic with hypoglycemia. Once we give some glucose or some chocolate, patient will regain his consciousness, his or her consciousness, or if we give some 25D, they will regain. Okay, so they are presenting with features of Whipple's triad. We have diagnosed it as insulinoma. Which of the following tumors should be actively screened in this patient? Okay, so what they are coming to say is, which of the following that is associated with MEN syndrome. MEN syndrome la the type of MEN syndrome la this insulinoma is associated. So there are 4 types of MEN syndrome: MEN 1, MEN 2A, MEN 2B, and MEN 4. Okay, in MEN 1 there can be pituitary tumors, parathyroid tumors, and pancreatic endocrine tumors. In this only we have this insulinoma. The most common pancreatic endocrine tumor, most common functional pancreatic endocrine tumor that is associated with this MEN 1 syndrome, that is gastrinoma. Gastrinoma is the most common tumor that is associated, followed by this insulinoma. Insulinoma is also associated with MEN 1 syndrome. So this MEN 1 syndrome, it includes pituitary tumors, that is pituitary adenoma, also pituitary hypoplasia, most commonly pituitary adenoma. Then parathyroid adenoma can also be associated. Also pancreatic endocrine tumors, most common functional is gastrinoma, followed by this insulinoma. So how are we going to remember this? Pit per pan. Okay, PPP 3 P வச்சு ஞாபகம் வச்சுக்க போறோம். So this MEN syndrome, what is the chromosome that is associated with MEN syndrome? Okay, MEN 1 இருக்கு, MEN 2 இருக்கு, also MEN 4 இருக்கு. So there is not an increasing order of chromosome. BRCA 1 we know BRCA 1 is associated with 17, whereas BRCA 2 is associated with 13. There is a decreasing pattern. அதே மாதிரி neurofibromatosis type 1 is associated with chromosome 17 and 2 is associated with 22. That's an increasing pattern. Here there is an irregular pattern. MEN 1 it is associated with chromosome 11. MEN 2 it is associated with chromosome 10. MEN 4 it is associated with chromosome 12. Okay, what gene that is associated with this MEN 1 syndrome is, that is menin gene. Menin gene it is associated with this MEN 1 syndrome. It is also called as Werner syndrome. Okay, what is Werner syndrome? There is another syndrome called as Werner syndrome. We must not confuse with that Werner syndrome. Werner syndrome it is associated with premature aging, progeria. Okay, premature aging. This Werner syndrome it is associated with premature aging. In ராட்சசன் மூவியில் வர மாதிரி, அல்லது அந்த பா மூவியில் வரக்கூடிய அமிதாப் பச்சன் மாதிரி, patient will be having a premature aging. That is seen in Werner syndrome. That has something to do with telomerase. Okay, here this is Werner, M for M for MEN 1 syndrome, M for menin gene, M for Werner syndrome. Okay, MEN 1 2 1 போட்டுக்கோங்க. Associated with chromosome 11. It is associated with pituitary tumors, parathyroid tumors, and pancreatic endocrine tumors. Most common is gastrinoma, followed by insulinoma. So the answer is, it is most commonly associated with, in the option என்ன இருக்கு, it is associated with pituitary adenoma. One more important point in here is this parathyroid adenoma. The parathyroid adenoma இருக்குல்ல, this parathyroid adenoma, it will be associated with MEN 1, MEN 2A as well as MEN 4. It won't be associated only with MEN 2B la mattum it won't be associated. It can be associated with MEN 1, MEN 2A and in MEN 4. Pituitary adenoma, it will be associated with MEN 1 as well as MEN 4. Okay, we are going to see that again. What is MEN 2A syndrome? MEN 2A syndrome, it is associated with chromosome 10. Chromosome 10. MEN 2A and 2B it is associated with chromosome 10. What gene is associated? We are going to put this 10 and we are going to reverse this 10. NET. We are going to change this N into R. So red. So red gene is associated with MEN 2A as well as MEN 2B. What chromosome is affected? That is chromosome 10 is affected. what are the tumors or what are the conditions that is associated? Most commonly it is associated with medullary thyroid carcinoma. Most common association is medullary thyroid carcinoma, followed by, we have already told, parathyroid adenoma is seen in men 1, men 2A and men 4. So parathyroid adenoma associated with pheochromocytoma. Also megacolon, congenital megacolon, that is Hirschsprung's disease, is also associated with this men 2A. So in a patient with medullary carcinoma of thyroid, we have to rule out pheochromocytoma. If the question is given as if patient is having a swelling in front of the neck, also patient is a young age group, patient is presenting with headache as well as palpitation, we have to suspect a pheochromocytoma. We have to rule out pheochromocytoma in order to If pheochromocytoma is there, then we have to suspect a MEN2A syndrome. We have to do a prophylactic thyroidectomy depending upon the exon mutation. In this MEN2A and MEN2B, MEN2B is more severe or more serious. There we are going to do prophylactic surgery, thyroidectomy very earlier compared to this MEN2A. Okay. Then men to B, here also it is associated with chromosome 10, it is associated with red gene mutation. Here everything starts with M. Okay, we have to remember with M. We are having a medullary thyroid carcinoma, it is more aggressive, we have seen. Okay, we are going to do a prophylactic surgery, immediately we diagnose this men to B syndrome. Then there will be morphanoid features, patient will be tall with thin arms. Okay, morphanoid features. There will be mucosal neuroma, there will be neuroma, medulated corneal nerve fibers will be there. Here also there will be megacolon, there will be Hirschsprung's disease. So Hirschsprung's disease, it is associated with chromosome 2A, men 2A as well as men 2B. So if men 2 is suspected, if all the first degree relatives has to be screened for this red mutation. Appo exon, we have to see the exon. If the exon is 618 or 634, it is associated with men 2A. If they are associated with low risk, we have to do a prophylactic thyroidectomy within 5 years. Okay, if there is a exon 918 mutation that is associated with men 2B, it is associated with high risk. We have to do a prophylactic thyroidectomy within 1 year of age. We are going to do a prophylactic thyroidectomy within 1 year of age in this patient. Next is the men 4 syndrome. It is associated with chromosome 12. In the gene CDKN1B gene. This is the least important among these men syndromes. It is associated with pituitary adenoma, parathyroid adenoma, similar to that of men 1 syndrome. Apart from this, there is no pancreatic tumors in this men 4 syndrome. In place of pancreatic tumors, it has been replaced with reproductive organ tumors such as testicular, renal and adrenal tumors. Okay, so this completes the men syndrome. A 62-year man presents with gradually worsening difficulty rising from chair and climbing stairs. His muscle strength transiently improves with repeated activity but later deteriorates, causing frequent falls. Chest X-ray, there is a hilar mass. What is the most likely association? So from this difficulty in rising from the chair or climbing stairs, there is some proximal weakness. Okay, proximal weakness. Also they have given there is a hilar mass. So some tumor is in the lungs. Okay, some hilar mass, so a tumor is suspected. So which tumor that is associated with this proximal weakness? Proximal weakness, that is suggestive of Lambert-Eaton syndrome or Eaton-Lambert syndrome. Okay, Eaton-Lambert syndrome. It is similar to that of myasthenia gravis. In myasthenia gravis, if you give steroids, it will improve. Whereas this Lambert-Eaton syndrome, it does not improve with steroids. It is associated with lung carcinoma, specifically with small cell carcinoma. Okay, small cell carcinoma paraneoplastic syndrome is this Lambert-Eaton syndrome. It is associated with this proximal muscle weakness. There will be proximal muscle weakness similar to that of myasthenia gravis, but they won't respond to steroids. So this small cell carcinoma, it is associated with Eaton-Lambert syndrome, number 1. It can also be associated with SIADH. Okay, SIADH. Also, it can also be associated with Cushing syndrome. SIADH can also be associated, can also be a paraneoplastic syndrome in intracranial tumors. Intracranial tumors there can be SIADH. Also this Cushing syndrome can also be seen in pancreatic tumors, renal cell carcinoma and neural tumors. In renal cell carcinoma, what is the most common paraneoplastic syndrome? That is increased ESR. Increased ESR is the most common paraneoplastic syndrome. Apart from that, hypercalcemia can also be seen in renal cell carcinoma. Polycythemia can also be seen in renal cell carcinoma, but the most common Cushing syndrome can also be seen in renal cell carcinoma, but the most common is increased ESR. This squamous cell carcinoma of lung, it will be associated with hypercalcemia. What is the paraneoplastic syndrome that is associated with this squamous cell carcinoma? It is hypercalcemia. It can also be seen in renal cell carcinoma, lymphoma and breast. Adenocarcinoma of lungs, it will be associated with hypertrophic primary osteoarthropathy, similar to that of clubbing. Also non-squamous small cell lung cancer, it will be associated with clubbing. Okay, it will be associated with clubbing. So what you have to know is Lambert-Eaton syndrome, it will be associated with squamous cell carcinoma, not small cell carcinoma of lung. Okay, string of bead appearance of bile ducts on ERCP, it is suggestive of what in கேட்டிருக்காங்க. They have given a clue. This condition, it is associated with cholangiocarcinoma, it is associated with gallbladder carcinoma, also it is associated with inflammatory bowel disease such as ulcerative colitis. Inga, how are we diagnosed it as a ERCP? We can see the endoscope here. If an image is given, how can we differentiate from a MRCP? If the endoscope image endoscope in the segment namakku theriyudhu appadina, that is a ERCP specimen. Okay, ERCP, they have given there is string of bead appearance in the bile duct. String of bead appearance in the bile duct, that is suggestive of primary sclerosing cholangitis. In histopathology, that is there will be onion peel appearance in this condition. In case of chronic pancreatitis, there will be string of bead or chain of lake appearance in the pancreatic duct. Okay, ERCP la paatho appadina, ERCP or MRCP la paatho appadina, there can be similar appearance, but it will be seen in the pancreatic duct. So we must not confuse from a chronic pancreatitis and primary sclerosing cholangitis. It is an extra-intestinal manifestation seen in ulcerative colitis. Okay, it does not improve with treatment. It is not associated with disease progression. Okay, a baby with Down syndrome. Okay, baby is having a Down syndrome, presents with delayed passage of meconium, abdominal distension and bilious vomiting. After perectal examination, meconium is passed. What is the investigation of choice? So patient is having a delayed passage of meconium, so meconium veliye varala, abdominal is going on distended, also there is a bilious vomiting. So food can't pass after the veliye varamatengudhu food, so patient is having vomiting, bilious vomiting. So the lesion is somewhere after the second part of duodenum, கீழ தான் எங்கேயோ lesion இருக்கு. Also there is abdominal distension, so large bowel related something is there. After perectal examination, we are doing some manipulation and patient is passing meconium. These all are suggestive of Hirschsprung's disease. Okay, Hirschsprung's disease or congenital megacolon, it is associated with this Down syndrome. What all syndrome also, where in a syndrome could is associated? It is also associated with MEN 2A and MEN 2B syndrome. We have seen now. Okay, MEN 2A and MEN 2B syndrome, it is also associated with this congenital megacolon. What happens here? There is the loss of ganglion, inhibitory ganglion cells in the myendric or Auenbar plexus. Okay, and the myendric plexus there is loss of ganglion cells, so there is loss of relaxation. So contraction la irukku, there is no relaxation. Relax anada stools adu valiya pass agum, there is loss of relaxation. Okay, so that can lead to this Hirschsprung's disease. In case of a children, they will be presenting with constipation symptoms. Okay, constipation symptom. What is the investigation of choice? Investigation of choice barium enema கிடையாது. Investigation of choice is a rectal biopsy. Okay, we are going to do a rectal biopsy. Rectal biopsy பண்ணி histopathology பார்த்தோம் அப்படின்னா there will be loss of ganglion cells. There will be loss of ganglion cells. Also there will be hypertrophic muscle fibers, hypertrophied muscle fibers. Also there will be increased acetylcholinesterase. Okay, increased acetylcholinesterase can be seen in this condition in case of a Hirschsprung's disease. Hirschsprung's disease, in the finding la irukum. What is the treatment then? What are the surgeries that can be done for this Hirschsprung's procedure? Surgery is SOAV, SOAS procedure can be done. Duhamel procedure can be done. Also Swenson's procedure can be done. These are the named surgeries that are done for Hirschsprung's disease. Just remember this, okay? SOAV, so Duhamel and Swenson. இந்த நேம் கேட்டாங்க அப்படின்னா எந்த சர்ஜரியோட எந்த டிசீஸோட அசோசியேட்டட்னா இட் இஸ் அசோசியேட் வித் Hirschsprung's disease. A 50-year-old was admitted with the history of left side femur fracture 12 hours back. He has now developed respiratory distress, tachypnea, desaturation இருக்கு. Patient is having confusion. There is also petechial rash. ECG la there is no specific changes. What is the most common diagnosis? So இந்த ஆப்ஷனை பொறுத்த வரைக்கும் myocardial infarction ஆயிருந்துச்சுன்னா there can be some changes in the ECG. Okay. Also in case of pulmonary thromboembolism, this deep vein thrombosis, where can this occur? It occurs after prolonged immobilization. Okay, long bone fracture ku vandu surgery pannadukku appuram it can present, this DVT can present, and DVT can progress into a pulmonary embolism. This all can occur after prolonged surgery or prolonged immobilization. Immediately after ஒரு ஃப்ராக்சர், ஒரு லாங் போன் ஃப்ராக்சர் நடந்ததுக்கப்புறம் என்ன நடக்கும் அப்படின்னா ஃபேட் எம்போலிசம் கேன் ஹேப்பன். ஃபேட் எம்போலிசம் கேன் ஹேப்பன் ஆஃப்டர் அ லாங் போன் இன்ஜுரி. ஓகேவா? இசிஜியில் தேர் இஸ் நோ ஸ்பெசிஃபிக் சேஞ்சஸ். இசிஜியில் தேர் கேன் பி சேஞ்சஸ் வித் பல்மனரி த்ராம்போஎம்போலிசம். You can comment the ECG changes of a pulmonary thromboembolism below in the comments. Okay, so ECG la changes illa, but patient is desaturating. Also other respiratory distress irukku, he is going for confusion. Also there is petechial rash. This triad, okay, respiratory incompromise, confusion, also petechial rash, all are suggestive of fat embolism. Fat embolism is associated with long bone fracture. A 60-year-old white man, okay, elderly white man presented with a rolled out pearly white lesion of size 1x1 cm with a central crest near the inner canthus of left eye. He has been working in the sun for a long duration. What is the most common diagnosis? Okay, according to the site, inner canthus of eye. Okay, what is more common in the inner canthus of eye? Or basal cell carcinoma. Basal cell carcinoma, it is more common in the inner canthus of eye, number 1. It is more common in white individual, number 2. It is more common in people working in the sun. Prolonged sunlight exposure, it is associated. Also it will be pearly white lesion with a central crest. In the image la irukka mari there will be a rolled out edges. Okay, edges வந்து rolled out ஆ இருக்கு. This edges, it is rolled out edges is there. Also there is a central crest. This is suggestive of basal cell carcinoma. What is the most common pathological type? That is nodular type. Nodular type is the most common type of this basal cell carcinoma. It is also called as rodent ulcer. Why it is called as a rodent ulcer? It doesn't spread இப்படி இந்த மாதிரி ஸ்ப்ரெட் ஆகாது. லோக்கல் இன்வேஷன் மட்டும்தான். ஒரு ரேட்டு அல்லது ஒரு ரோடன், ஒரு ரேபிட் மாதிரி பரோ மாதிரி தோண்டி உள்ளே மட்டும்தான் போகும். ஓகேவா? தேர் இஸ் நோ லிம்ஃபாட்டிக் ஸ்ப்ரெட். ஸோ இட் இஸ் அ ரோடன் டியூமர். இட் இஸ் ஆல்சோ கால்ட் அஸ் அ ரோடன் டியூமர். இதில் என்ன சர்ஜரி பண்ணலான்னா மோக்ஸ் மைக்ரோஸ்கோபிக் சர்ஜரி கேன் பி டன். ஓகே, ஸோ இந்த இடத்துல வி கான் டூ எக்ஸிஷன் with margin கொடுத்து wide local excision மாதிரி we can't do if the tumor is in the inner canthus of eye. Okay, vital structures எல்லாம் damage பண்ணிரும். So இந்த Mohs microscopic surgery is done. Okay, repeatedly we are going to remove the repeatedly tumor எடுத்து pathology எடுத்து பார்த்து margins எல்லாம் வந்து free ஆகிற வரைக்கும் we are going to excise the tumor. Small bit we are going to excise. A 60-year-old man with a 35-year history of employment in a shipyard undergoes routine occupational health assessment. His long-term exposure places him at a high risk of developing bronchogenic carcinoma and malignant mesothelioma. Which of the following agents is most likely responsible? Okay, which of the following agent is responsible for mesothelioma, also for lung cancer? That is asbestos. Okay, asbestos exposure nala patient can get asbestosis. bronchogenic carcinoma varlam, also pleural tumor mesothelioma can also come in a patient who is exposed to asbestos. Okay, wood dust exposed ana they can have a nasopharyngeal tumor. Patient can have a nasopharyngeal tumor. Aniline dyes exposure can lead to bladder carcinoma. Vinyl chloride can lead to angiocarcinoma of liver, angiosarcoma of liver, or hepatocellular carcinoma of liver. This asbestos, it is associated with lung cancer as well as asbestosis. Also it can be associated with mesothelioma. So vinyl chloride we have already seen, hepatic angiocarcinoma or HCC. Asbestos, it is associated with mesothelioma, lung cancer. Also beryllium, cadmium, chromium, arsenic, these metals can also be associated with lung cancer. Wood dust, it is associated with paranasal, okay, nasopharynx, anga irukka paranasal sinus la they can cause tumor. Aflatoxin and the plant fungal toxins that can lead to hepatocellular carcinoma. Also benzidine is an important causative agent for, this is also recently asked, okay, benzidine is an important causative agent for this bladder carcinoma. Also aniline dyes, naphthalene, rubber, this exposure to these materials can cause bladder carcinoma, okay, transitional cell carcinoma of bladder. A 41-year-old woman presented with a palpable mass in the left breast. What is the investigation of choice? Okay, a direct question. Investigation of choice for a breast carcinoma, you must not confuse, it is not FNAC, it is a core needle biopsy. This excisional biopsy, that is removing the total tumor, it can give a 100% diagnosis. It is the gold standard, but the investigation of choice, எல்லாருக்கும் போயிட்டு மொத்த டியூமரை ரிமூவ் பண்ணிருக்க முடியாது. Okay, so investigation of choice is a core needle biopsy or true cut biopsy. FNAC la we can't do ஹார்மோனல் ரிசெப்டார்ஸ் ஸ்டடி பண்ண முடியாது, ERPR பாசிட்டிவா என்னன்னு சொல்லிட்டு பார்க்க முடியாது. அதே இது if you do a core needle biopsy we can also see the hormonal receptor status. Okay, so this core needle biopsy, it is the investigation of choice in a case of breast carcinoma. Which of the following statement is true about Trendelenburg position? What is this Trendelenburg position? We are going to keep the leg above and the head below. Okay, Trendelenburg position, இந்த மாதிரி பொசிஷன்ல வச்சு சர்ஜரி பண்ண போறோம். we can do for varicose vein surgery, rectal surgeries க்கு வந்து இத பண்ணலாம். ஓகே, கீழ இருக்கு பண்ணக்கூடிய சர்ஜரிஸ்க்கு we can do this. இது பண்ணும்போது என்ன ஆகும், இந்த கண்டென்ட் எல்லாம் கீழ போகும். it can cause pressure over the diaphragm. okay, diaphragmல pressure cause பண்ணி it can also cause increased intrathoracic pressure. அதே மாதிரி blood it can go and stasis in the head, தலைக்கு போகும். so there will be increased intracranial pressure, increased cerebral vascular pressure, also கண்ணுக்கும் pressure அதிகமா போகுது. There can also be increased ocular pressure. So the answer for this, it is all of the above. It can be, there can be increased cerebral vascular pressure, increased intraocular as well as increased intracranial pressure. Which of the following correctly describes a neoadjuvant chemotherapy? What is this neoadjuvant chemotherapy? Chemotherapy is given before surgery. It is called as neoadjuvant chemotherapy. Okay, chemotherapy given before surgery. Okay, surgery பண்ணதுக்கு முன்னாடி பண்ணக்கூடிய chemotherapy or radiotherapy that is given before a surgery. Surgery முன்னாடி பண்ணக்கூடிய இது that is called as neoadjuvant. What is an adjuvant chemotherapy? Something that is done after surgery. Surgery முடிச்சதுக்கு அப்புறம் பண்றது that is adjuvant. What is a palliative chemotherapy? எதுமே பண்ண முடியாது, there is no other go, only this is done as a palliation கொடுக்க போறது, that is palliative chemotherapy. A 58-year-old man presents with a progressive weight loss, altered bowel habits and intermittent episodes of blood in stools for the past 4 months. Colonoscopy reveals a ulceroproliferative lesion in the sigmoid colon. Histopathology, it comes from a adenocarcinoma of colon. Mutation of which of the following genes is most commonly associated with this malignancy? So they have given a sigmoid colon malignancy. Okay, so it is a colon malignancy. Colon la edu most common pathological type, that is an adenocarcinoma. Adenocarcinoma the most common pathological type. Rectal carcinoma adenocarcinoma da. In case of an anal carcinoma, it is squamous cell carcinoma. Colorectal carcinoma, what is the most common site? Most common site in a colorectal carcinoma is rectum. Okay, rectum the most common site, number 1. What is the apart from that second most common site is the sigmoid colon. rectum வந்து நமக்கு ஆப்ஷன்ல இல்லனா we are going to choose sigmoid colon. அதுக்கப்புறம் cecum. Okay, next is cecum. Cecum அதுக்கப்புறம் வருது. So most common left side tumors are most common than right side tumors. left side tumors it presents with இந்த கொஸ்டின்ல இருக்கிற மாதிரி bleeding per rectum ஓட present பண்ணுவாங்க. altered bowel habits, loose stools, constipation மாறி மாறி present பண்ணுவாங்க. ஓகேவா? also there is weight loss. ஒரு டியூமர்னா வெயிட் லாஸ் இருக்கும். இன் கேஸ் ஆஃப் அ ரைட் சைட் டியூமர், சீக்கம்ல அந்த இடத்துல டியூமர் இருக்குது அப்படின்னா பேஷண்ட் பி பிரசனிங் வித் அயர்ன் டெஃபிஷியன்சி வரீங்க ஆர் தே கேன் பி பிரசனிங் வித் மாஸ். ஓகே, மாஸோட தே கேன் பிரசன்ட். ஸோ தீஸ் ஆர் த ஃபீச்சர்ஸ் ஆஃப் colorectal carcinoma. இப்போ என்ன கேட்குறாங்க அப்படின்னா which of the following mutation, எந்த ஜீனோட mutation is most commonly associated among the optionsல. ஓகே, for that we have to know about adenoma carcinoma sequence. ஓகே, மோஸ்ட் காமனாக ஒரு கார்சினோமா டெவலப் ஆகுதுக்கு adenoma carcinoma sequence is only going to happen. ஓகே, பாலிப் மாதிரி ஃபார்ம் ஆகி அதுலேருந்து டியூமர் வரப்போகுது. ஓகே, இந்த adenoma carcinoma sequence ஏபிசி ஜீன். ஓகேவா, ஏர்லியஸ்ட்டாக ஒரு நார்மல் ஒரு கோலான் இருக்குது, அந்த கோலானில் போயிட்டு ஃபஸ்ட்டு எந்த இதை அட்டாக் பண்ணுதுன்னா ஏபிசி. இட் இஸ் அசோசியேட்டட் வித் ஃபெமிலியல் அடினோமேட்டஸ் பாலிபோசிஸ். அதோட குரோமோசோம் வந்து நம்பர் 5. ஓகே, அந்த ஏபிசி ஜீன் தான் ஃபஸ்ட்டு அடி வாங்குது. ஓகே, ஏர்லியஸ்ட். அதுக்கப்புறம் என்ன ஆகுது, இட் இஸ் ஃபார்மிங் இன்டு அ அடினோமா. ஏர்லி அடினோமா ஃபார்ம் ஆகுது, லேட் அடினோமா ஃபார்ம் ஆகுது. ஏர்லி அடினோமா, லேட் அடினோமா. இந்த ஸ்டேஜில் என்ன நடக்குது அப்படின்னா ஏர்லி அடினோமா வந்து KRAS மியூட்டேஷன் இஸ் ஹேப்பனிங். லேட் அடினோமாவில் வந்து டிசிசியோட மியூட்டேஷன் இஸ் நடக்குது. அதுக்கப்புறம் லேட் அடினோமாவிலேருந்து கார்சினோமாவுக்கு மாறும்போது லேட்டாக தான் என்ன நடக்குது, P53 mutation is going to happen. So APC is associated, KRAS is associated, DCC is associated, also P53 is associated. So in the option la edu correct answer, that is KRAS mutation. இதெல்லாமே polyp related. Okay va? So there is some alternate pathway. Polyp இல்லாமலே ஒரு டியூமர் வரலாம். It is associated most commonly Lynch syndrome. Okay, non-hereditary non-polyposis coli syndrome, HNPCC. Lynch syndrome, HNPCC. There is no relation to polyp. இதில் என்ன இருக்கும், there is mismatch repair of MSH, MLH. Okay, இந்த ஜீனோட mismatch repair is happening in case of an alternate pathway. Alternate pathway la there is no polyp. Okay, hereditary non-polyposis coli syndrome. Okay, HNPCC, also known as Lynch syndrome. So we have seen earliest attack பண்றது APC gene, that will lead to familial adenomatous polyposis. எந்த குரோமோசோமில் இருக்கு, குரோமோசோம் 5. important, it is associated with autosomal dominant. இந்த colorectal carcinoma associated polypல மோஸ்ட்டாக எல்லாமே it will be autosomal dominant. சர்ஜரி பார்க்கக்கூடிய எல்லாமே மோஸ்ட்டாக தெரியல அப்படின்னா go for autosomal dominant. ஓகே, இதுலேயே MUTYH அசோசியேட்டட் பாலிபோசிஸ் தான் autosomal recessive. அதை தாண்டி ஒரு வேரியண்ட் ஆஃப் டர்காட் சிண்ட்ரோம். ஓகே, டர்காட் சிண்ட்ரோம் இஸ் அ எக்ஸ்ட்ரா இண்டஸ்ட்ரியல் மேனிஃபெஸ்டேஷன் ஆஃப் திஸ் FAP. அது ஒரு ரேர் கண்டிஷன் தான், அதுவும் autosomal recessive. அதை தாண்டி எல்லாமே autosomal dominant தான். ஓகே, so it is autosomal dominant. 200 is going to come, more than 100 polyp. இந்த இமேஜில் பார்த்தீங்கல்ல, there will be more than 100 polyp. There is 100% risk for colorectal carcinoma. FAP இருந்துச்சு அப்படின்னா familial adenomatous polyposis is there is going to be a colorectal carcinoma. Okay, most common tumor associated வந்து colorectal carcinoma மட்டும் இல்லை, it is associated with, most commonly it is associated with periambulary carcinoma. Okay, ஏதாவது ஒரு carcinoma வரப்போது, most commonly periambulary carcinoma. It can also be associated with colorectal carcinoma. Diagnosis, either colonoscopy can be done, sigmoidoscopy can be done. They can ask you the centimeters length of this. Sigmoidoscopy length வந்து 60 cm previously asked. Okay, sigmoidoscope வந்து sigmoid வரைக்கும் தான் போகுது, லெஸ்ஸாக தான் இருக்க போகுது 60. அதே இது colonoscope வந்து it can vary, size can vary, it can vary from 100 to 160. இந்த ரேஞ்சில் கொடுத்தாங்கன்னா you are going to choose it as a colonoscope length choose பண்ண போகிறோம். Next, what are the extra intestinal FAP மட்டும் இல்லாமல் if there is some associated manifestations, it can be Gardner syndrome or Turcot syndrome. Okay, Gardner syndrome, it is autosomal dominant. There can be familial adenomatous polyposis with osteoma, facial osteoma. Okay, small tumors, osteomal tumors. அப்புறம் desmoid tumors, இங்க anterior abdominal wall, soft tissue tumor over the anterior abdominal wall. Also கண்ணில் CHRPP, congenital hypertrophy hypertrophic retinal pigmental epithelium that is be present in the eye. Facial osteoma, CHRPE. அப்புறம் வந்து abdominal என்ன இருக்கு? There is desmoid tumor. Also there can be epidermoid cyst. Epidermoid cyst can also be seen. Also in Turcot syndrome, how are you going to remember Turcot syndrome? Turcotல turban ஞாபகம். Turban எங்க வைப்பாங்க? தலையில வைப்பாங்க. So it is associated with CNS manifestation. It is associated with CNS tumors. Okay, there is two type of Turcot syndrome, type 1 and type 2. Type 1 is autosomal dominant, type 2 is autosomal recessive. சொன்னேன்ல that one single autosomal recessive is coming here. Okay, Turcot syndrome type 2 is autosomal recessive, type 1 is autosomal dominant. It will be associated with glioma. Type 2 will be associated with medulloblastoma. Okay, this will be associated with medulloblastoma. How are we going to manage? It has 100% risk for developing into a colorectal carcinoma. So we are going to do a proctocolectomy, removal of the entire colon along with the rectum. That is total proctocolectomy with ileal pouch anal anastomosis. Okay, ileum anasையும் இது கனெக்ட் பண்ணி ஒரு பவுச் மாதிரி கிரியேட் பண்ணி we are going to anastomose. That is ileal pouch anal anastomosis. This is the treatment done for familial adenomatous polyposis. How are we going to screen? If the first degree relatives ஒரு patient வந்து colorectal carcinoma diagnose பண்ணிட்டோம் from FAP இருக்கு colorectal carcinoma இருக்கு diagnose பண்ணிட்டோம், you have to screen the first degree relatives for this APCG. APCG அந்த first degree relative இருக்குன்னா we have to screen the patient. For 10 years we are going to screen, continuously we are going to screen, we are going to do a sigmoidoscopy. எப்போ tumor develop ஆகுதோ or எப்போ polyp develop ஆகுதோ we are going to do a prophylactic surgery. Total proctocolectomy with IPAA, ileal pouch anal anastomosis. Suppose if the screening is negative, we are going to manage similar to that of a general population. எப்படி வந்து colorectal carcinoma வந்து screen பண்ண போறோமோ அந்த மாதிரி screen பண்ணா போதும். MUTYH associated polyposis அதான் பார்த்தோம். The only autosomal recessive, it will be pre-malignant. Lynch syndrome. Here it is HNPCC, hereditary non-polyposis colonic carcinoma syndrome. There is no polyp associated. Okay, polyp illa. This is also autosomal dominant. இது வந்து alternate pathwayல பார்த்தோம்ல mismatch repair of MSH and MLH. Okay, there can be associated malignancies. Okay, most common extracolonic carcinoma is endometrial carcinoma or uterus. அதாவது endometrial carcinoma or tumor of the uterus, followed by gastric, followed by ovarian. There is also a variant of this Lynch syndrome, that is Muir-Torre syndrome. It will be associated with multiple cutaneous adenoma sebaceum. It will be associated with sebaceous gland tumors. Okay, this Muir-Torre syndrome, it is nothing but a variant of this Lynch syndrome. In the Lynch syndrome, we are having a criteria called as modified Amsterdam criteria. Okay, what is this modified Amsterdam criteria? 3 or more family members with Lynch syndrome related cancer. Okay, colorectal, endometrial, small bowel, ureter, renal pelvis or stomach cancer or ovarian cancer, some tumors. Okay, 3 or more family members must have, one of whom is the first degree relative of the other two. Okay, இப்போ ஒரு பேஷண்ட் இருக்காங்க அப்படின்னா அவங்களுக்கு either அவங்க அம்மா first degree related அம்மா அல்லது father, also அந்த பேஷண்டோட பையனுக்கோ பொண்ணுக்கோ வரலாம். ஓகே, அந்த ஒரு பேஷண்ட் ஹேஸ் டு பி ரிலேட்டட், ஃபர்ஸ்ட் டிகிரி ரிலேட்டடாக இருக்கணும். ஓகே, ஸோ whom is a first degree relative of the other two, or 2 or more successive affective generation. ஓகே, ஒரு பேஷண்டோட அம்மா அப்பா இஸ் அஃபெக்டட், ஆர் அம்மா அப்பாவை தாண்டி தாத்தா பாட்டி அஃபெக்டட். ஸோ 2 or more successive generations are affected with this Lynch syndrome. At least one tumor is diagnosed. ஒரு டியூமர் அட்லீஸ்ட் less than 50 இயர்ஸ்க்கு கீழே டயக்னோஸ் பண்ணணும். எஃப்ஏபியை ஃபஸ்ட்டு எக்ஸ்க்ளூட் பண்ணணும், அதான் மோஸ்ட் காமனாக வரப்போகுது. ஆல்சோ இட் ஹேஸ் டு பி வெரிஃபைட் பை pathological examination. This is the modified Amsterdam criteria. Modified Amsterdam criteria comes under Lynch syndrome. Next is the hematomatous polyp. Hematomatous polyp la வந்து that can be juvenile polyposis syndrome associated with chromosome 18 SMAD4. Next, Cowden syndrome. Cowden syndrome, it is associated with chromosome 10. Okay, Cowden 10. Okay, den னு வச்சுக்கோங்க, den 10 P10. Cowden chromosome 10 P10, okay, P10 gene mutation, chromosome 10 Cowden syndrome, okay. It is associated with thyroid carcinoma, breast carcinoma. It can also have GI polyp. It is not pre-malignant for GI malignancy. It can also be associated with trilymoma, okay. அடுத்து இம்பார்ட்டன்ட் இஸ் பியூச் ஜுகர் சிண்ட்ரோம், ஓகே. ஒரு பேஷண்ட் வந்து கொடுக்குறாங்க, பேஷண்ட் இஸ் ப்ரெசென்டிங் வித் ஒரு பாலிப்போட ப்ரெசென்ட் பண்ணுறாங்க. ஆல்சோ தர் இஸ் பெரியோரல் மெலனோசிஸ், இம்பார்ட்டன்ட், ஓகே. பெரியோரல் மெலனோசிஸ் பாலிப்பு சொல்கிறாங்க. ஆர்எல்ஸ் பேஷண்ட் இஸ் ப்ரெசென்டிங் வித் இன்டர்செப்ஷன் ஆர் ஒரு ஸ்மால் பவுல் அப்ஸ்ட்ரக்ஷனோட ப்ரெசென்ட் பண்ணுறாங்க வித் பெரியோரல் மெலனோசிஸ் சொல்லிட்டு இந்த மாதிரி இமேஜ் கொடுக்குறாங்கன்னா வி ஹாவ் டு diagnose it as Peutz Jeghers syndrome. Very important, associated with chromosome 90, இதுவும் autosomal dominant, STK11 gene mutation. just இதை தெரிஞ்சு மட்டும் வச்சுக்கோங்க. there can be multiple hematomatous polyposis in the small intestine and colon. small bowel intussusception can happen. there is increased GI malignancy. it is also pre-malignant. it's also a pre-malignant condition. Then another one thing, patient is presenting with a GI polyp. also there is some penile hyperpigmentation. it can be asked, okay, penile hyperpigmentation, what is this syndrome called? that is Banyan-Riley-Ruvalcaba syndrome. it can be asked. இந்த perioral melanosis மாதிரி penile pigmentation இருக்கு with GI polyp இருக்கு, that is Banyan-Riley-Ruvalcaba syndrome. A 33-year-old man presents with a painless enlargement of right testis for 3 months. there is no history of trauma or infection, okay. trauma illa, infection illa, so also there is history for 3 months, so it rules out Tarsal testis, also epididyma archaeocele we are going to rule out. serum beta HCG and AFP levels are within normal limits, okay, it is normal. Histopathological shows large cells with clear cytoplasm separated by fibrous septa containing lymphocytes, okay. histopathology we can leave it as it is, adu pathology la paathukalam. how are we going to rule out here, okay. here there is normal AFP னு கொடுத்திருக்காங்க. AFP is elevated in case of embryonal tumors such as yolk sac tumors, teratoma, choriocarcinoma. மூணுலயுமே there will be elevation of AFP. also in case of a choriocarcinoma there will be elevation of beta HCG, okay. there can be elevation of beta HCG as well as AFP in case of a choriocarcinoma. teratoma, yolk cell tumor la there can be elevation of AFP. in case of seminoma there will be no elevation of AFP will be normal in case of a seminoma. also in the age group, also it is the most common testicular tumor. how will they present? they will be presenting as a painless enlargement. there will be a painless testicular mass, pain irukadu, okay. A 48-year-old man presents with a colicky abdominal pain, progressive abdominal distension, vomiting, inability to pass flatus for the past 24 hours. erect x-ray is done. what is the most likely diagnosis, okay. here what can we see? we can see a step ladder pattern, okay. we can see a step ladder pattern. also we can also see there is valvulae connivens, okay. valvulae connivens are seen, okay. valvulae connivens are suggestive of small intestine. valvulae connivens, okay. connivens, it is suggestive of small intestine, okay. என்ன இருக்கும்? there will be step ladder pattern, அதுக்கப்புறம் line can be seen completely, okay. also from the question patient is having vomiting will be first developing in a small bowel obstruction, okay. small bowel obstruction la வந்து patient will be developing vomiting. அதுவும் first proximal small bowel la earliest patient will be developing vomiting. அதே இது patient be having minimal distension in case of a small bowel obstruction, whereas in case of a large bowel obstruction patient will form distension earlier, vomiting later, okay. vomiting will be present later. so idhula important point is there is step ladder pattern. also there is bowel loops present centrally. in case of large bowel there will be bowel loops present in the periphery la irukum. also there will be haustra இந்த valvular connivence இருக்காது. There will be haastra. இந்த இமேஜ்ல இருக்க மாதிரி haastra இருக்கும். This haastra it will be incomplete. இந்த மாதிரி full லைனுக்கு வராது. ஓகே, full லைனுக்கு வராது. There will be incomplete இருக்கும். Incomplete hastration will be seen in case of a large bowel obstruction. எங்க இருக்கு? பெரிஃபெரியில இருக்கு. பெரிஃபெரியில இருக்கு. In case of small bowel இந்த இமேஜ்ல கரெக்ட்டா தெரியுது. This valvular connivence it will be complete. There will be complete transversations. Okay, transverse lines வந்து கம்ப்ளீட்டா இருக்கு in case of a small bowel obstruction. Mostly it will be seen in the center. அதே இது இங்க it will be seen in the periphery. Okay, here in case of a small bowel obstruction there will be 3 centimeter dilation. Okay, 3 centimeter dilation. அதுக்கப்புறம் இந்த வேற bowel இது descending colon and the colon எல்லாம் it can dilate up to 6 centimeter, whereas this cecum it can dilate up to 9 centimeter. That is the 3:6:9 rule. Okay, small intestine 3 centimeter, colon எல்லாமே 6 centimeter, whereas large இது cecum it can dilate up to 9 centimeter. A 25-year-old man is brought to the emergency department after a road traffic accident with the loss of consciousness. A non-contrast CT is shown in the figure. What is the most likely diagnosis? Okay, idhula eppadi theriyudhu? We can see a lens shape. Okay, lens shape or biconvex shape or swelling irukku. Okay, it is suggestive of extradural hemorrhage. Extradural hemorrhage it will be எந்த ஷேப்ல இருக்கும்? இந்த மாதிரி லென்ஸ் ஷேப்ல இருக்கும். or else how can we remember? ஒரு இட்லியை சைடுல பார்த்த மாதிரி இருக்கும். இட்லி, E for இட்லி, E for extradural or epidural hemorrhage. Okay, so it will be seen outside the dura. Duraக்கு வெளியே இருக்கு. Okay, so we are having the dura mater, arachnoid mater, pia mater. This is the dura, this is the arachnoid, this is the pia mater. So in case of extradural hemorrhage எங்க இருக்கும்? The swelling will be present outside the dura mater. இங்க தான் என்ன இருக்கும்? Sutures will be there. So this extradural hemorrhage it can't cross the suture line. Suture line cross பண்ண முடியாது. ஓகே, suture line க்கு உள்ள தான் இருக்க போகுது. Plus it is also caused by, most commonly caused by damage to the middle meningeal artery. So it is an arterial bleed. அப்போ என்ன பண்ணும்? How will be the arterial bleed? ஒரு வெசல் கட் ஆகுது, arterial bleed எப்படி இருக்கும்? இப்படி அப்படி ஊத்தும். அதே இது venous bleed there will be oozing, arterial bleed there will be spurting. ஓகேவா? ஸோ arterial bleed என்ன பண்ணும்? அதால சைடில் போக முடியாது. ஓகேவா? ரெண்டு சைடும் என்ன இருக்கு? there are sutures. அப்போ என்ன பண்ணும்? It will push the brain. அப்போது அதனால தான் அது என்ன ஷேப்பு அட்டைன் பண்ணுது? இந்த மாதிரி ஒரு ஷேப் வருது. ஓகே, ஸோ இதை இந்த சூச்சர் லைனை தாண்டி போக முடியாததுனால இட் இஸ் கம்மிங் டுவர்ட்ஸ் தி பிரெயின். அதனால் பிரெயினை புஷ் பண்ணுறதுனால இட் இஸ் கிவிங் அ லென்ஸ் ஷேப்ட் அப்பியரன்ஸ். ஓகே, ஆர் பைகான்வெக்ஸ் அப்பியரன்ஸ். ஓகே, ஸோ இதை புஷ் பண்ணுறதுனால இட் கேன் காஸ் அ midline shift. Okay, இது push பண்ணி it can cause midline shift. Also lucid interval is associated with this extradural hemorrhage. Okay, lucid interval na enna? Patient will be having a loss of consciousness followed by regaining consciousness. கொஞ்ச நேரம் he will be conscious, after that he will lose his consciousness. Okay, so this lucid interval it is most commonly seen in this extradural hemorrhage or epidural hemorrhage. Next, in the image la irukkudu it is a subdural hemorrhage. Okay, so டியூராக்கு கீழே இந்த இடத்துல பிளட் போய் கலெக்ட் ஆகுது. இட் இஸ் சீன் பிலோ தி டியூரா. தேர் இஸ் நோ சூச்சர் லைன், இட் கேன் கிராஸ் தி சூச்சர் லைன். ஓகேவா? ஸோ அதனால தான் இது இங்கேருந்து இங்கே வரைக்கும் இருக்குது. அது வந்து இட் இஸ் ரெஸ்ட்ரிக்டட் விதின் த சூச்சர் லைன், இட் கேன் கோ இங்கேருந்து அங்கே வரைக்கும் போகுது. ஆல்சோ இட் இஸ் அ வீனஸ் ப்ளீட். ஓகே, பிரிட்ஜிங் வெயின்ஸ் தான் இதில் அஃபெக்ட் ஆகுது. வீனஸ் ப்ளீட் என்ன? அவ்வளோ ஃபோர்ஸாக இட் கான் புஷ் த பிரெயின், அவ்வளோ சக்தி அதுக்கு கிடையாது. அதனால் என்ன ஆகும்? இந்த சைடு பார்த்து போகுது. That's why it is going like this. Okay, இந்த சைடு it is going, plus அங்கே சூச்சர் லைன் இல்லை. ஸோ அந்த மாதிரி போயிட்டு அந்த போய் செட்டில் ஆகுது. ஸோ இட் இஸ் லைக் அ சிக்கிள் ஷேப். ஓகே, ஒரு சிக்கிள், ஒரு அருவா மாதிரி இருக்குது. எஸ் ஃபார் எஸ், சிக்கிள் ஷேப். ஆல்சோ இட் கேன் ஆல்சோ லுக் லைக் அ crescentric shape or concavo convex shape. இது எல்லாமே suggestive of subdural hemorrhage. It is associated with என்னது? bridging veins. ஒரு venous bleedனால இது வருது. Next is a subarachnoid hemorrhage. Okay, arachnoid membrane கீழே இருக்கு, இதுதான் subarachnoid hemorrhage. இங்க என்ன ஆகுது, arachnoid membrane கீழே போகுது. ஸோ blood வந்து எங்கே கலெக்ட் ஆக முடியும், அந்த டியூரா கைரே இருக்குல்ல, அந்த கேப் இருக்குல்ல, அங்கே போய் தான் கலெக்ட் ஆகும். அதனால தான் இந்த மாதிரி லைனாக தெரியும். இந்த மாதிரி ஒரு லைனாக போய் அந்த கைரேக்கு நடுவில் போய் கலெக்ட் ஆகிறதுனால இட் இஸ் லுக்கிங் லைக் அ லைன், ஒரு மாதிரி லைனாக இட் இஸ் கோயிங் டு லுக். திஸ் இஸ் subarachnoid hemorrhage. Subarachnoid hemorrhage. Trauma the most common cause. Second most common cause is ruptured berry aneurysm is the second most common cause for this subarachnoid hemorrhage. அடுத்து this is intraventricular hemorrhage. இங்க இருக்கிற ventricles இருக்குல்ல, black கலர்ல இருக்குது ventricles, அதில் போய் ஒரு blood collection இருந்துச்சுன்னா that is IVH, that is intraventricular hemorrhage. It is associated with bad prognosis. சப்போஸ் ஒரு கொஸ்டின் கொடுக்குறாங்க, ஆர்டிஏ முடிச்சு வராங்க, பேஷண்ட்க்கு வந்து சிடிக்கு தராங்க, சிடியில் ஃபைண்டிங்கே இல்லை, எந்த விதமான ஹெமரேஜுமே இல்லை, பட் பேஷண்ட் ஜிசிஎஸ் இஸ் வெரி புவர். அதுக்கப்புறம் ஜிசிஎஸ் இஸ் வெரி புவர், சிடி நார்மல், ஜிசிஎஸ் இஸ் புவர், பேஷண்ட் இஸ் ஹேட் ஆர்டிஏ, என்ன சஸ்பெக்ட் பண்ணுவீங்க, தட் இஸ் டிஃப்யூஸ் ஆக்சோனல் இன்ஜுரி. Diffuse axonal injury, MRI is the investigation of choice. மிச்ச head injury கெல்லாம் CT is the investigation of choice, non-contrast CT is investigation of choice, similar to that of stones மாதிரி, renal stones மாதிரி. ஆனால் in the case of diffuse axonal injury, MRI it is the investigation of choice. Patient post thyroidectomy presented with the above sign, that is twitching of the facial muscles on tapping the facial nerve. It is a image based question, video based question. இந்த மாதிரி ஃபேஷியல் நர்வ் வந்து ட்விச் பண்ணுறாங்க, இது ட்விச் பண்ணும்போது அதை வந்து டேப் பண்ணும்போது there is twitching of the facial muscles. Okay, so what is this sign and எது கூட it is associated? Okay, this sign is என்ன sign? This is Chau-Stokes sign. It is associated with hypoparathyroidism following thyroidectomy. It is associated with என்ன electrolyte imbalance? Hypocalcemia. It is associated with hypocalcemia. Also trachea sign, அதாவது பிபி கஃப் வந்து above the பேஷண்டோட நார்மல் பிபிக்கு மேலே கெட்டும் போது பேஷண்ட் கேன் கோ ஃபார் இந்த மாதிரி கார்போபிடல் ஸ்பாசம் போவாங்க, தட் இஸ் trachea sign. That is also associated with this hypoparathyroidism. Herb sign, it is also associated. This hypocalcemia, how are we going to manage? We are going to see the calcium levels. If the calcium level is more than 8, we are going to give the patient with oral calcium and oral vitamin D3. If the patient has the calcium level less than 8, we are going to give IV calcium gluconate. Okay, over 10 minutes கொடுக்க போறோம், IV calcium gluconate கொடுக்க போறோம். கொடுத்துட்டு then we are going to also give oral calcium as well as oral vitamin D3. So that completes the FMG paper. All the best for your examination. Thank you.